Welcome back, my friends, and welcome to USMLE with me. This is where we get ready for exam day, going over high yield content, test taking strategies, content review, everything really in between. Why don't we get into it? And this is a high yield question. It's a cardiac case. Remember, cardiology is super high yield for all of our exams. This one is focused on valvular heart disease. So, if you'd like, go ahead and give yourself 90 seconds to answer this question by yourself. Otherwise, we're going to go ahead and do it together. All right, here we go. So, which of the following findings is most likely expected in this patient? Here we have a 75-year-old woman, history of hypertension, chronic kidney disease. She's presenting with progressively worsening dyspnea and fatigue over the past 6 months. Now she's experiencing shortness of breath while walking short distances and notice swelling in her legs. Reports mild chest pain, occasional lightheadedness. Medications include lisinopril, furosemide, and atorvastatin. Here's her physical exam. Blood pressure 130 over 85, heart rate 85, respiratory rate 18, O2 sat 96%, JVD is present. Cardiac auscultation reveals a loud systolic crescendo-decrescendo murmur. Lungs are clear to auscultation, but bilateral pitting edema is noted in the lower extremities. Here's our TTE. Aortic valve area, zero point 0.8 centimeters squared. Left ventricular ejection fraction, 50%. FYI, that's on the lower range of normal, so 50 to 70% is considered normal. Peak aortic jet velocity, 4.5 meters per second. This is considered slow. Okay, and guidelines would show that this indicates severe aortic stenosis. Which of the following findings is most likely expected in this patient? This is something that USMLE exams have been doing increasingly more often. What it is I'm sure you were reading this question. Here's an older patient, history of hypertension, lightheadedness, which is kind of syncope, angina, she's got the chest pain, and pretty profound dyspnea. And she's got isolated systolic hypertension, she's got JVD, and boom, here's this murmur, systolic crescendo, decrescendo murmur. And you're thinking, bingo, aortic stenosis. I got this question right. 260, 270 score, here I come. Except for the very next line, they tell you aortic valve area, zero point 0.8 centimeters squared. Yikes, they gave you the diagnosis. This happens all the time. You're thinking, I got it, I got the diagnosis. And then the question writer just gives that to you in the question, and it's very frustrating. That's why a lot of times students leave their exam. They say, "Well, I thought I studied really hard, but they didn't ask me anything I knew." Actually, they're asking you everything that you know. They're asking the same concepts. They're just hitting it from different angles. They're approaching the concept from places that maybe you have not seen before. This is a good example of that. So why don't we dive into this and take a look? Let's evaluate answer by answer. And by now, I hope you've chosen an answer. Choose an answer, commit to it. Don't worry, and let's see how we're doing. So why don't we evaluate answer A, starting from the top, displaced point of maximal impulse. So this is going to be seen in mitral regurgitation. Okay, and what's going on in mitral regurgitation is during systole, your left ventricle is squeezing, ejecting that blood out of the left ventricle past the aortic valve into systemic circulation. During this time, your mitral valve should be closed. Well, during mitral regurgitation, that mitral valve is leaky. And so during systole, some of your blood is actually going back into the left atrium. Now, during diastole, that additional blood is being used to fill up your left ventricle in addition to the blood that was already there in the left atrium. And what's going on here is you might imagine it's kind of like a balloon. You're filling a balloon with more water and more water and more water. Eventually, that left ventricle is going to dilate. It's not meant to have that much volume. And actually, this is going to be eccentric heart failure. You're going to hear an S3. This is going to be a volume overload. And on physical exam, you're going to have a displaced point of maximal impulse. But here it's pretty clear we're dealing with aortic stenosis. A is not a physical exam finding that we would necessarily most commonly see in aortic stenosis. It's more likely associated with mitral regurgitation. So we can eliminate that. Why don't we look at letter B? And so this is a well-known one. You can tell me which of the cardiac valvular defects would give you this finding of bounding pulses and a widened pulse pressure. Okay, great job. If you said aortic regurgitation, you're spot on. Okay, what's going on in aortic regurgitation? And let me just say, as an aside, there are some tools out there. There are some, I guess, some resources out there where you draw some kind of a circle and you use some kind of a mnemonic, and somehow you memorize which murmurs are systolic versus diastolic. I would not recommend memorizing physiology. I would not recommend, especially cardiac physiology. You have to understand what's going on. So why don't we talk about what's going on during aortic regurgitation? Okay, so we know what's happening during systole. That left ventricle squeezing, you're shunting blood out of the left ventricle through that open aortic valve into systemic circulation. Well, on the flip side, during diastole, the aortic valve is supposed to be closed, and you're actually moving blood from the left atrium pumping through the mitral valve into the left ventricle. And that's how you get your volume for the oncoming systole. Well, what's going on in aortic regurgitation is during this time, the aortic valve is inappropriately open. It's leaking. And so blood from the proximal aorta is able to leak back during diastole into the left ventricle. So there's something that happens here. That additional blood now becomes part of the ejected blood volume in systole. So your systolic pressure is increasing, right? As you're filling the left ventricle, you have additional blood coming in from the proximal aorta. That same blood during systole is now being ejected. So your systolic pressures are increasing. But during diastole, some of that blood is actually coming back into the left ventricle. So instead of making the rounds, instead of going into systemic circulation, your organs, everything, making it all the way back to the right side of the heart, instead of that, some of that blood is just coming right back into the left ventricle during diastole. So actually your diastolic pressure is decreasing. So your systolic pressure is increasing while your diastolic pressure is decreasing. This is going to cause a widened pulse pressure. Remember, pulse pressure is systolic blood pressure minus diastolic blood pressure. That's why you see this finding in aortic regurgitation. But of course, here we're talking about aortic stenosis. All right. And we're going to move on here to this next answer choice. Why don't you say out loud this is one that students definitely is very high yield. Students know about this one. So which cardiac valve defect is going to more commonly lead to left atrial enlargement and atrial fibrillation? Very good. So that's going to be mitral stenosis. Here's what's going on. During diastole, your left atrium is essentially contracting against a stiffened or stenosed mitral valve. What happens over time is that left atrium is going to hypertrophy. And that left atrium, the movement, the motion, the wall motion of that left atrium is going to become irregular. It's going to become desynchronized compared to the movement of the ventricles. And therefore, mitral stenosis itself is actually, in fact, a complication of mitral stenosis is atrial fibrillation. There are two other super high yield complications of mitral stenosis that they love to go after on exams. Unfortunately, these are relatively less common in real life, but they're more common on exams than they are in real life. You hate it when that happens, right? But they do this because this is your hint. There is an anatomic component that comes into play here, and this is why they love to go after this. So can you tell me what are those two anatomic components which are complications of mitral stenosis? All right, so number one is you have this left atrium which is enlarging. It can directly compress the esophagus, and that can lead to dysphagia. Okay. The next one is it can actually compress the recurrent laryngeal nerve. This can lead to hoarseness. So these are the two super high yield complications of mitral stenosis leading to left atrial enlargement, and then these high yield anatomic tie-ins that they can use on these exams. Now, just to check that you're still listening. So what is the most common cause worldwide of mitral stenosis? If you said it's rheumatic heart disease, complication of rheumatic fever, you're absolutely correct. What is another possible cause? Not the most common, but what is another possible cause? Maybe you're saying lupus. That's correct, SLE. Okay, so those are just a couple of high-yield tie-ins. By now, I hope you chose an answer for yourself. And if you chose answer D, that's the correct answer. So a soft and single second heart sound. This is referring to what happens in aortic stenosis. Okay, so a little bit about aortic stenosis. This is the most common cardiac valvular defect in industrialized countries. The incidence increases with age, so typically you have an elderly patient. Typical symptoms are like those that we showed in this question: syncope, angina, dyspnea. Okay, and what can happen is that this valve, because it's stenosed, it closes ineffectively. And so actually it can either close a little bit slowly. Therefore, when you hear those two heart sounds, actually it'll close at the exact same time as the pulmonic valve. Therefore, you won't actually hear that second heart sound at all. But it can also actually not close at all. And that in those situations with severe aortic stenosis, you can actually also see aortic regurgitation just because the valve is not able to close at all. Management of this would be surgical. Now, there's something in this question that I was working with a student one-on-one, and again, I provide this for students. I provide coaching, step 1, step 2, clinical shelf exams, even basic sciences exams. I was a teaching assistant throughout the basic sciences, so I really love those courses and going over that. At any rate, I was working with a student, and they said, well, Shaan, right here, this patient has JVD. This patient has bilateral pitting edema in the lower extremities. How do they have clear lungs? Why are the lungs clear to auscultation? And that's a really good question. So what happens is with aortic stenosis, you have eventually you have hypertrophy of the left ventricle. You're going to hear an S4 sound, you have left-sided heart failure, you have these pressures being backed up to the pulmonary vein, eventually to the pulmonary arteries, you have pulmonary arterial hypertension. You can absolutely have volume in the lungs. You can absolutely have, you can have positive physical exam findings such as rales in the lungs. It's possible. Left-sided heart failure leading to right-sided heart failure, and then there you get your JVD, you get your bilateral pitting edema. You might even have something called a hepatojugular reflux. So the question is, in this scenario, why are their lungs clear? And the answer is, in advanced stages of right heart failure. In advanced stages of right heart failure, actually, the right heart can actually become so weak and so ineffective that it's not able to effectively pump blood volume or significant blood volume into pulmonary circulation. So if you have a situation like this, whether it's a patient or a question, and you've got evidence of right-sided heart failure, you know that the right-sided heart failure is definitely coming from the left side, and yet you don't have you don't have any rales in the lungs, or you don't have physical exam findings in the lungs. There's a likelihood that this is advanced disease. There's a likelihood that this is very advanced disease, and that is the case here. So that's just a little bit on that. Now here you're going to see answer E is jugular venous distension, which increases with inspiration. So not to get confused, that is referring to Carvalho's sign. Okay, so that is Carvalho's sign. This is an increase in the intensity of tricuspid regurgitation with inspiration, and so this is a finding that is associated with tricuspid valve disease. Not to get confused with pulsus paradoxus. Okay, we can't cover all of cardiology. We'll probably talk about these things moving forward too. But pulsus paradoxus is an exaggerated drop in systolic blood pressure during inspiration. So if you remember, that's a hallmark of cardiac tamponade, where the blood doesn't fill properly due to pericardial fluid compressing the heart chambers. And there's some separate physiology there. So just pointing out that those are two separate things. Okay, so these are your answer explanations. You can pause the video. You can take a look at your leisure. And here are your key takeaways. So we talked about the soft or single second heart sound due to calcification of the aortic valve. Another finding is weak and delayed pulse, pulsus parvus aortis, weak and delayed pulse. Remember, that is in opposition, or that is essentially the opposite of the water hammer pulse or the bounding pulses that we see in aortic regurgitation. And then number three here is differentiating valvular pathologies. Nowadays, it's not enough to just recognize the murmur. We know that aortic regurgitation, that is a diastolic decrescendo murmur. We know that mitral stenosis is a mid-diastolic murmur with an opening snap, like it's that rumbling murmur with an opening snap. So we know these key words, but then what they end up doing is they ask you about the physical exam findings and some things you might see in association. So hopefully number three will help you with that in our key takeaways. And then finally, the treatment is aortic valve replacement. There are different methods of aortic valve replacement. There's balloon valvuloplasty, there's transcatheter AVR. There are different approaches. I don't think it's super high yield to know which patient population and which particular surgical approach you use. I think the bottom line is that when you have severely symptomatic aortic stenosis, surgery is going to be an option. It's going to be an option that you entertain very seriously. So thanks so much for tuning in. I want to wish you all the best. Of course, I'm available if you need any help. I just want to say here, it's a Sunday as I film this. I plan on taking the rest of the day off. Depending on what day it is for you that you're accessing this, remember, you should schedule a day off. At least one day out of 7 to 10 days, you should schedule it off. The benefit of scheduling it is that you don't feel bad. You don't feel bad about taking that day off. Also, the benefit of scheduling it is you can make the most of it. You can get reservations at a restaurant. You can make plans to go to a beach. You can make plans with your friends or your family. You can watch a movie in the theaters. Go out and do something. Have fun. Fun should be part of your dedicated period of study. Fun should be part of your medical school journey. Fun is important for your exam. I'm telling you, having fun and enjoying yourself and releasing stress, it is good for your exam scores. Too often I see students, they say, well, I'm just going to be a robot, study for 5 months straight or 3 months straight. And we're not built like that. We're human beings. And it's actually healthy for you to have a good time every now and again. Okay, so at least one day out of every 7 to 10 days, I recommend a complete day off. Okay, so with that being said, I wish you the very best. Keep grinding, keep working hard, and as always, happy studying.